Assalamu alaikum everyone. Welcome to DentoScope Studio, the official YouTube channel of DentoScope Institute of Advanced Dentistry. I am Dr. Rashid Hassan, the founder and CEO of DentoScope, and we have started a live lecture series by DentoScope mentors. And today I am joined by Dr. Ammarah Afreen. She is FCPS in Operative Dentistry and Endodontics, and she is going to brief us today about the cracked tooth syndrome. So over to you, Dr. Ammarah.
Thank you, sir. Assalamu alaikum, ji. Today, the topic that we are going to discuss is cracked tooth in operative dentistry. And whenever you are dealing with patients, so one of the very difficult diagnosis is that of a cracked tooth. So that is why we discussed, and I wanted to share my knowledge and the etiology as well as the basic management that we can do for a cracked tooth. So defining a cracked tooth is actually a type of longitudinal tooth fracture. The American Association of Endodontics, they have identified 5 types of longitudinal tooth fracture that include craze line, fractured cusp, cracked tooth, split tooth, and vertical root fracture. I'll just give a brief definition of each type, and then we'll move towards the cracked tooth. The types of cracked teeth, you can see in this figure a fractured cusp in which a part of the cusp is fractured, a crack running through the center of the tooth, but it is still treatable. When this crack becomes a split tooth, then the tooth cannot be fixed. So the earlier the diagnosis, the better would be the prognosis of your treatment. A craze line, so initial first longitudinal type of fracture is a craze line. Craze line is the initial tooth crack that occurs on the enamel surface parallel to prismatic orientation by occlusal forces. It only affects enamel, originates on the occlusal surface, typically from occlusal forces or thermocycline, and they are usually asymptomatic. No treatment is required for craze line. A fractured cusp is defined as a complete or incomplete fracture that is initiate crown से होता है and it extends subgingivally, usually directed both mesiodistally as well as buccolingually. So directed, now you can see in this figure that it is directed both mesiodistally as well as buccolingually. It originates in the crown, extends into the dentine. It terminates, however, it terminates in the cervical region, and it is associated with large restoration, causing this defect. A cracked tooth. Now, the topic that we are going to discuss today, what is a cracked tooth? It is not a complete fracture. It is an incomplete fracture that is initiated from the crown. It extends subgingivally and usually directed mesiodistally. It is not directed buccolingually, and that's why we cannot see it in a radiograph. रेडियोग्राफ में हमें हमेशा से वो चीज़ नज़र आती है जो कि बक्कोलिंगुअली प्रेजेंट होती है, क्योंकि वो 2D डायमेंशनल, इसीलिए क्रैक टूथ का डायग्नोसिस बहुत डिफिकल्ट है. ये आपको सिंपल जो आप ओपी जो रेडियोग्राफ कराती हैं, पेरिएपिकल रेडियोग्राफ, उसमें नज़र नहीं आता. It can also be defined as a crack extending from the occlusal surface apically without separation of the two segments. Now you can see without the separation. Once the separation occurs, it is referred to as a split tooth, and no treatment of that is possible. Cracked tooth can still be treated. So the जो point यहाँ पे बार बार emphasize करने का है कि earlier the diagnosis, the better would be the prognosis. Occlusally, it is centered occlusally and extends more apically than a fracture curve, and it may be likely to cause pulpal and periapical pathosis because it extends apically. Now, split tooth, as already discussed, when the incomplete fracture of a cracked tooth becomes complete, then it is referred to as a split tooth. It is defined as a complete fracture that is initiated from the crown and extending subgingivally. It is usually directed mesiodistally, like a cracked tooth, through both of the marginal ridges and the proximal surfaces, splitting the tooth completely into two separate segments. Now here, the tooth is not salvageable, and this will require extraction. Now, you can see what I have been discussing, the progression of a crack. If it is not treated, the crack is going to progress and becoming a split tooth that is non-salvageable. Now, vertical root fracture is a complete or incomplete fracture from the root at any level, and it is usually directed buccolingually. Cracked tooth syndrome. Now, already discussed, it is defined as an incomplete fracture of a vital posterior tooth involving the dentine and possibly the dental pulp. Recently, the definition has included a fracture plane of unknown depth and direction passing through the tooth structure that may progress to communicate with the pulp and periodontal ligament. So this crack can communicate with both the pulp, leading to pulpal necrosis, and it can also cause periodontal ligament infection if left untreated. Other names for cracked tooth is cuspal fracture or dentalgia, green stick fracture, cracked cusp syndrome, split tooth syndrome. Now, every uh, every disease has a predisposing factors. So what is the predisposing factor for cracked tooth syndrome? The predisposing factor now can be excessive occlusal forces on a healthy tooth. कि दांत आपका healthy है, but उसके ऊपर excessive forces आ गई, या normal forces on a weakened tooth structure. And sometimes, very rarely, inappropriate handling of dental materials can also be the cause of cracked tooth syndrome. Now, examples of excessive forces like masticating accidents, such as chewing on an unexpectedly hard food particle, can result in high concentration of force. Very bit जोर से आपने bite कर लिया किसी भी चीज पे, a fall or blow on the face. Sports is another common cause of tooth fracture. Parafunctional activities are also thought to be a major contributing factor. Now you can see in this picture, like biting on an almond, you have suddenly bit on something that's very hard, or parafunctional habits. These are excessive forces on healthy tooth. Now, normal forces on a weakened tooth structure. Your tooth has already been weakened. The forces are normal, but the tooth has already been weakened. Now, how can the tooth be weakened? Endodontic treatment has been implicated as a risk factor. Pins or posts that have been placed in teeth for additional means of retention will almost always result in additional tooth structure being removed, making the tooth weak. So now this tooth being weak will not be able to uh, withstand the normal occlusal forces. So these are the example of normal forces on a weakened tooth structure. Third, now you can see a large intracoronal restoration, placement of the pins or post in the teeth, endodontic treatment of the tooth that makes the teeth weak. Dental materials. The water contamination of amalgam results sometimes in dimensional expansion, leading to crack in teeth. Curing of a large increment of composite can result in excessive shrinkage. Finishing a restoration so that it is high in bite may also lead to a fractured tooth. Forces generated during lateral condensation of gutta percha can sometimes be very excessive and can lead to apical fracture of apical portion of the root. Very rare events, like modern trend for piercing of body parts, has led to reports of cracked tooth syndrome associated with piercing of the tongue. That is leading to ये जो piercing tongue की हुई है, ये इस central incisor, lateral incisor को continuously pinch कर रही है. That might result in formation of a crack in the lateral incisor. Loss of tooth substance due to internal resorption. Very rare causes. No. So etiology. Predisposing factors हमने पढ़ लिए. Now coming over to etiology. There are some natural predisposing features, some iatrogenic causes. Iatrogenic means during dentistry जो आप कर रहे हैं, use of rotary instruments, cavity preparation, width and depth of the cavity. Natural predisposing like bruxism, clenching, lingual inclination of the lingual cusp of mandibular molars and steep cusp fossa of the maxillary premolars, they have predisposed to cracked tooth in these teeth. Then flags that are associated with cracked teeth. Class 1 restoration with excessive interference, Class 2 restoration with inadequate cuspal protection, plunger cuspis, steep cuspal inclines, hypertrophic masticatory muscle, abrasive diet and or parafunctional habits, previous history of cracked teeth, unrestored root canal treated teeth, non-carious cervical lesions, and intracoronal pins. They have all lead to a tooth that is weakened and hence predisposing the tooth to undergo crack. Now, pain mechanism. Why there is a pain when there is a crack? There is short, sharp pain, which is because of the fluid movement in the dentinal tubules when the fracture fragments is separate during application of pressure. This is due to stimulation of mechanoreceptors in close proximity to odontoblastic cell bodies. This then activate the A delta fibers. But as already discussed, it might involve the crack, might sometimes involve the pulp, in which case C fibers may be involved, and this might lead to pain that is of dull and prolonged pain rather than short, sharp pain. Epidemiology. Which teeth are usually involved? It usually affects the adult dentate patients that are typically in the range of 30 to 60 years. Incidence is 34 to 74%. Occurrence in older patients is thought to be caused by loss of dentine elasticity, increased number of restorations, and increased stress fatigue over time. Sex. It has been shown that frequency of cracks among females is higher because of behavioral patterns leading to better dental care. However, other studies have shown that males show more cracks because of more advanced development of their masticatory muscles. However, other studies have shown that there is no sex-related difference in crack tooth. Teeth. The cracks are more prevalent in mandibular molars. Mandibular molars, they are the most tooths that are involved in cracked teeth. Palatal cusp of maxillary molars could act as a plunger that induces the structural fatigue in the mandibular antagonist. However, why not maxillary molars? Maxillary molars have a transverse ridge, which may provide structural reinforcement and account for the lower incidence of fractures in these teeth, as compared to mandibular molars. Molars, premolars, and incisors have a bite force ratio of 4:2:1. Thus, the molars that are close to the temporomandibular joint, they have a higher occurrence of cracks. Now, it is more frequent in molars, as already been discussed, and in molars, mandibular molars. Second molars, they have an incidence of 27.3. First molars have an incidence of 9.1. For premolars, second premolars have an incidence of 21.2, and first premolars have an incidence of 18.2. Now, you can see when the amalgam restoration and class 2 restoration, they resulted in 2.4 times more cracks compared with class 1 restoration. When this class 2 was removed, you can see that a crack can be seen running through the cavity floor. Mechanism of crack formation. Initially, microcracks form as a result of cusp fracture caused by occlusal load during mastication and repeated thermal expansion of the restorative material. This might be attributed to physical properties such as thermal expansion coefficients and elastic modulus. Amalgam and gold, they have a higher thermal expansion coefficient compared with these, and thus they are more likely to cause the cracks. In contrast, porcelain has a similar thermal expansion of coefficient to that of teeth and therefore of favorable restorative material. Composite resin, they have a relatively large thermal coefficient, but it may also generate a small dimensional change because it undergoes polymerization shrinkage. Furthermore, the low elastic modulus of resin and adhesive layer could be caused by compensation for thermal expansion and occlusal stresses. Prognosis. What is the prognosis of a cracked tooth? Earlier recognition can help to avoid the propagation into the pulp chamber or the subgingival area. अगर subgingival area involve हो गया आपका या pulp की necrosis होगी, then prognosis become poor. Loss of pulp vitality may result in a poor prognosis of cracked teeth, and endodontically treated teeth show survival rate of only 85.5% after 2 years. Prognosis that involves both marginal ridges or involves the subpulpal floor is less favorable. Pocket dip. अगर pocket बन गई इसके साथ, periodontal ligament involve हो गया crack के साथ. All pre-treatment periodontal pockets were isolated pockets, and the patients did not have periodontal disease. A deep probing depth means that a crack has progressed deep into the root surface. Periodontal pockets can therefore act as a pathways for further infection, resulting in loss of the teeth. Cracked teeth showing a deep periodontal probing more than 4 mm, they have a poor prognosis, and proportion of persisting symptoms was higher. Fracture necrosis. What is fracture necrosis? Pulp becomes non-vital with no subjective or obvious cause for the necrosis. That is, there is no deep restoration or no caries. In that case, you must consider that a crack could have progressed, causing to the necrosis. It can be concluded that there is a high probability that a crack is the cause for the necrosis, referred to as a fracture necrosis. In addition, as the crack persists further apically and to a lateral surface, associated bone resorption typically occurs in the furcation, lateral root surface, crestally as well as apically. Now, what happens? What leads to this fracture necrosis? Bacteria from the oral cavity as well as the periodontal ligament space, they enter the crack and they progress down the root and into the bone subadjacent to the crack. Left undetected, or in the event that the tooth becomes split, the periodontal bone loss may be so extensive that bone grafting may be necessary before the placement of dental implant or a fixed bridge. सो अब फ्रैक्चर नेक्रोसिस एक दांत अगर आपको ऐसे ही लगा कि उसके अंदर कोई केरीज या रेस्टोरेशन नहीं है और उसके अंदर नेक्रोसिस हो गया, सो क्रैक मे बी अ वेरी इंपॉर्टेंट कॉज लीडिंग टू नेक्रोसिस. इन दैट केस नेक्रोसिस इज रेफर्ड टू एज फ्रैक्चर नेक्रोसिस. डायग्नोसिस. द डायग्नोसिस इज मेड फ्रॉम हिस्ट्री. जैसे हमने पढ़ा कि कोई बाइट कर लिया, सो इट इज मेड फ्रॉम 3 पॉइंट्स: हिस्ट्री, क्लिनिकल एग्जामिनेशन एंड स्पेशल टेस्ट. Then I'll move to the last segment after this diagnosis, to the treatment of a cracked tooth. So first, history में आपने क्या पूछा? Pain or biting or on eating. Sometimes the pain is felt on release of biting, referred to as a rebound pain. Pain जो usually होती है sharp या brief होती है and occurs during chewing tough or hard food. It typically lasts only for a few seconds. Increase in sensitivity to hot and cold and sweet, depending on how far the crack is extended into the dentate. Patients will avoid eating on that side of the tooth. Inability to locate the tooth or even the jaw the painful tooth is sometimes. आपसे कभी कभी डायग्नोस नहीं हो रहा होता कि कौन सा दांत इन्वॉल्व है, पेशेंट वो पूरी साइड को कह रहा होता है कि इन्वॉल्व है. Now coming over to clinical examination. Clinical examination आपको कैसे करनी चाहिए? Magnification, a bright light, and a dry field of vision will make easier. Rubber dam can be used to isolate. Dentine cracks are sometimes difficult to see with a naked eye. So in this case, जो चीज important है, that is your special test. Tip of a sharp probe can be used to run along the tooth surface and may catch on the line of crack. Sometimes a localized periodontal pocket, as already discussed, कि sometimes crack के along एक बहुत deep pocket, isolated pocket होती है, मुंह में कहीं pocket नहीं होती, सिर्फ उस crack के along होती है, may indicate a crack that extends subgingival. Now, special tests that can be performed include the bite test, sensibility or vitality test, transillumination, staining, removal of the restoration, orthodontic bands, and radiograph. Bite test. Bite test, individual tooth itself may not be tended to percussion. मेन अच्छा, अब आप दांत को बाइट कराते हैं तो पेन नहीं होती. पेन में भी elicited with pressure applied to the individual cusp. जिस cusp के नीचे क्रैक रन कर रहा होता है, उस cusp के नीचे पेन होती है. Many methods have been suggested that includes आप हर cusp के ऊपर cotton wool roll रख लें, saliva ejector रख लें या tooth slot रख लें, as seen in this figure. कि tooth slot individual cusp पे बाइट कराए पेशेंट को, तो जिस cusp के नीचे क्रैक होता है उसको पेशेंट को बहुत सख्त पेन होती है whenever he or she bites. Vitality testing. Tooth in earlier stages जो हमने पढ़ा fracture necrosis नहीं होता. In that cases will give a positive response. But sometimes bacterial contamination may lead to pulpitis and tooth hypersensitivity. In that case, the tooth will give a negative response or to EPT or vitality. Transillumination. ये तो बहुत easy method है क्योंकि अब आपके पास हर clinics में हर वक्त आप लोग के पास curing light available होती है. Transillumination has been used to identify the cracks using a fiber optic light. So composite curing light is placed against the side of the tooth and transmission is seen. The fracture will tend to eliminate, this will eliminate the fragment of the tooth up to but not beyond the fracture. Staining. Methylene blue stain को use कर लें. This method is more time consuming as the dye needs to be sealed in the cavity for a few days. Other forms of the dye have been suggested that include iodine and gentian violet, caries detector dyes, and fluorescent dyes. Now, you can see that dye को place कर दिया आपने उसके अंदर, so that will make the cracks more visible. cracks visible हो जाते हैं, but it has to be left in the teeth for several times. Removal of restoration. कभी-कभी बहुत पहले की restorations पड़ी होती हैं, तो removal sometimes facilitate the visualization of cracks and allow the exploration of the cavity floor. It is not uncommon for the vibration of the dental handpiece to result in a crack becoming a complete fracture with subsequent loss of part of the tooth. Now, sometimes you remove the whole restoration and you can see a crack as seen in this figure. Sometimes you remove the whole restoration, a crack can be seen progressing through the cavity floor. Orthodontic bands. Now, these orthodontic bands are not only a diagnostic method, but they are also the treatment method. The application of an orthodontic or copper band is a useful procedure to confirm the diagnosis of cracked tooth syndrome. Cementation not only stabilizes the crack and prevents further movement. If symptoms are elevated, this confirms the diagnosis, and this is actually the first line management as well. जब हम ये मैनेजमेंट में जाएंगे तो ये पहली मैनेजमेंट होती है जिसमें हम ऑर्थोडोंटिक बैंड्स लगाते थे to prevent the progression of the crack and therefore elevate the symptom of the patient. Radiographs. मैंने पहले बताया था radiographs, they are unreliable in diagnosing the cracked teeth. The cracks are often not visible on radiograph because either the cracks are incomplete or the cracks they run in a mesodistal direction. The radiographic signs may be visible in the later stages with the involvement of the periodontal ligament. Radiograph में आप फिर क्या देख सकते हैं? You can only see caries, you can see defective fillings, periodontal infections and sinusitis, but you cannot see a crack because cracked का मसला ही है कि crack is incomplete and it is running in a mesodistal direction. So आपको crack radiograph में नजर नहीं आएगा. Recent advances OCT, optical coherence tomography, is a technique that uses low coherence interferometry to determine the echo time delay and magnitude of the backscattered light reflected from a transparent or semi-transparent structure. It is a non-invasive technique that is used for creating cross-sectional images of internal biological structures. Now, prevention. पहले तो चीज हमेशा होनी नहीं चाहिए. So how could you prevent cracked tooth? The restoration should preserve as much of the structure as possible. इसीलिए हमने पढ़ा कि class 2 restorations it is more common as compared to class 1. Minimizing the excess cavity for endodontic teeth. Occlusal contour should be as to maintain the correct cusp-fossa relationship. Overcarving should be avoided as this can lead to tooth movement. Or an alternate for cusp at risk is cuspal coverage restoration, like an ONLAY, cuspal, or even an amalgam or composite that is covering the cusp that is in danger of undergoing a crack. Now, how will you manage if sometimes agar aapke paas a patient aa gaya, how will you manage? The emergency as well as the definitive treatment of a cracked tooth will be dictated by the pulpal status, whether pulp involved hui hai or whether it has extended subgingivally or not, and the restorability of the tooth. Pulpal status. If the pain is short, sharp pain due to pressure, it may be indicative of an uninfected pulp, while a more lingering ache or hot and cold could indicate a greater degree of inflammation due to bacterial inflammation. If the pulpal status is uncertain, the tooth should be stabilized and reassessed before a definitive restoration is placed. Now, restorability. Restorability, the extent of the crack is not usually a factor where the fracture is incomplete and not displaced. Complete or displaced fractures require the fragment to be removed and will normally require the restoration to be placed over the fracture fragments. Where the fracture margins are more than 2 mm below, crown lengthening sometimes may be required. Teeth with a lack of coronal tooth structure have a poorer prognosis. Now, this is a diagnosis. If the patient comes with mild cold sensitivity and mild bite pain, you should provide him or her with a provisional crown or orthodontic bands. If the symptoms are resolved, then immediately provide the patient with permanent crown and review after 6 months. If the symptoms are continued, then do the root canal treatment and give a permanent crown and review after 6 months. If unfortunately, even after root canal treatment and permanent crown, symptoms are continuing, then you have to go for extraction. Sometimes patient will present with severe cold sensitivity, spontaneous pain, pulp necrosis, chronic epicardial periodontitis. In this case, both the treatment have to be done in the first visit, that is root canal and application of a provisional crown or an orthodontic band. If the symptoms are resolved, you have to provide the patient permanent crown. On the other hand, if the symptom continues, then go with extraction of the tooth. Emergency treatment. Patient बहुत pain में आपके पास आती है. So aim of the emergency treatment is to relieve the pain and to make the mouth comfortable and to improve the function. सबसे पहला काम जो करना है cracked tooth में is to stabilize the tooth. The tooth should be stabilized to prevent the further propagation of the crack and damage to the tooth. Teeth with symptoms of reversible pulpitis and incomplete fracture, they are treated just with stabilization. However, an irreversible pulpitis or pulpal necrosis both requires extirpation of the pulp in addition to stabilization. Extraction is indicated if the tooth is unrestorable. So, क्या treatment आपका? अगर reversible pulpitis है या incomplete fracture है, so that will only be treated by the application of a provisional crown or an orthodontic band. However, if irreversible pulpitis has occurred or pulpal necrosis, then pulpectomy or root canal treatment has to be done in addition to providing a provisional crown on an orthodontic band. Stabilization आप कर किससे सकते हैं? Teeth that have been stabilized should be reviewed 2 to 4 weeks following the placement. Once the tooth is stabilized, it should be unwise to proceed with a definitive restoration unless the tooth becomes asymptomatic. Failure to stabilize, अगर आप stabilize time पे नहीं करेंगे तो आपने incomplete fracture को complete बना दिया. Can lead to a complete fracture which may be a disaster for the tooth. आप खुद extraction की तरफ उसको lead कर दें. So best method क्या कर सकते हैं? Use of a stainless steel orthodontic bands. A temporary restoration can be placed with reinforced zinc oxide based cement. Copper bands can be used. A full acrylic crown can sometimes be used successfully. Definitive treatment. Definitive treatment will depend on the extent of the crack, loss of any tooth structure, restorative material, and patient preference for a particular type of treatment. You can go for a direct restoration or you can go for indirect restoration. For indirect restorations, amalgam can be used with cuspal coverage. Teeth restored with amalgam overlays have fracture energies equal to that of an intact teeth. So it is used as an interim treatment while waiting for the cast restoration to be made. So it is not a definitive treatment. आप इसके बाद उसको metal का crown देते हैं after amalgam restoration. Bonded amalgam can also be used. The amalgam physically and chemically forms a bond, which is self-curing. Clinical performance has been shown to be comparable to those carried out with traditional micromechanical means of retention. Composites can be used. Bonded resin composites have been used successfully. Similarly, glass ionomer cements, even when reinforced, has inadequate bond strength to hold the fracture. Glass ionomer cannot be used. Amalgam को use कर सकते हैं, bonded amalgam को use कर सकते हैं, composites को भी use कर सकते हैं. Now, best treatment is to provide them with an indirect restoration, like an inlay restoration, indirect restoration with cuspal coverage like onlays, conventional adhesive metal onlays. अब onlays आपके पास metal के भी हो सकते हैं, ceramic भी हो सकते हैं, indirect bonded resin composite onlays हो सकते हैं, and full coverage crowns can be given. Now, aesthetic, एक चीज जो इसमें add मैंने सिर्फ की, क्योंकि this is actually a new thing. Aesthetic resin onlay restoration. So what is an aesthetic resin onlay restoration? It is actually an onlay that is made of composite and it is made in the laboratory. It is one such dental restoration which has emerged from adhesive dentistry evolution that has gained a considerable popularity as an alternate to traditional conventional gold onlay. So आप gold की बजाय aesthetic resin onlay दे सकते हैं. They are more commonly fabricated from either metallic alloys, ceramic, or resin composites. They are also referred to as adhesive hats or bonnets. Now, this is an aesthetic resin onlay. आप देख सकते हैं कि बिल्कुल दांत की शक्ल का है. Preparation is that type of an onlay, और आप इसको ceramic या composite से बनाते हैं. That is usually made in the laboratory. आप इसको लेबोरेटरी में बना के और इस तरह दांत के ऊपर सीमेंट कर देते हैं. एडिसिव सीमेंटेशन होती है. इन कंपैरिजन टू डायरेक्ट कॉम्पोजिट, फायदा क्या है लेबोरेटरी में बनाने का? इट हैज मोर फेवरेबल एनाटॉमिकल फॉर्म, इट हैज अ मोर एक्यूरेट ओक्लूजल प्रिस्क्रिप्शन, इट हैज अ मोर प्रेडिक्टेबल proximal contact anatomy, and polymerization shrinkage is largely negated with the use of indirect techniques. So aesthetic resin onlays are actually composite onlays, but they're made in the laboratory with the following advantages. In comparison, और porcelain से क्या फायदा? ease of repair क्योंकि composite को आप directly repair कर सकते हैं. They are also less abrasive towards opposing occlusal surfaces. Adhesive onlay restorations can also be used in addition to metallic onlays. Metallic का क्या नुकसान है? Adhesive they offer superior static, they have ease of repair, they may be readily polished with minor adjustments, can be added to any adjustment without any difficulty. So treatment आप क्या कर सकते हैं? Treatment आप कर सकते हैं direct restorations and indirect restorations. Indirect restoration में आप inlays भी दे सकते हैं, onlays भी दे सकते हैं. Onlays में आप metal onlays दे सकते हैं, ceramic onlays दे सकते हैं, aesthetic resin onlays दे सकते हैं. Aesthetic resin onlays के बारे में मैंने इसलिए डिस्कस किया क्योंकि these are the latest advancements and they refer to as adhesive bonnets. Now अगर दांत extract हो गया तो फिर क्या कर सकते हैं? फिर implants can also be considered for the replacement of a cracked tooth with a poor prognosis. It is maybe desirable to delay the extraction until the implant is ready for placement. This will help to maintain the bone structure and prevent any alveolar shrinkage that is associated with post-extraction healing process. Now, these are actually the all the references from which this presentation has been made. I've added this at the end rather than in every slide, and you can also confirm the references. And that is all about cracked tooth. Any questions are more than welcome, and I'll be happy to answer if any of you have any questions.
Thank you very much, Dr. Ammarah, for brief lecture on the cracked tooth syndrome. There are a few comments regarding the lecture. Let me show them. Still waiting for any questions. If there are any questions, you are free to ask them. Okay. Okay. Thank you so much, Dr. Ammarah, for your time and this.
Most welcome.
Delivered. Inshallah, we'll contact you soon for some other topic. Inshallah, for DentoScope viewers.
Definitely, sir. It will be my pleasure.
Thank you so much, man.
Thank you, Amna. Thank you, Shees. And like क्वेश्चन हो तो आप बेशक पूछ भी सकते हैं, वरना बाद में पूछ लें अगर अभी नहीं पूछना तो.
हाँ, अगर कोई क्वेश्चन हो तो they can ask in the comment section
जी,
and I will
बिल्कुल.
let you know.
Thank you, sir. Thank you.
Thank you so much. Take
Welcome.
care. Allah Hafiz.
Allah Hafiz.